Thank you so much. My favorite audience to speak to is my colleagues, right? I love talking to pediatricians, and the reason is because I really believe that we are on the front lines of addressing the public health crisis that is adverse childhood experiences and toxic stress. And then the other reason is just that I love medicine and I love science, and I get to be more science-y when I talk to my colleagues. So I'd love to start by sharing with you just a bit about my experience, how I came to be looking at this research and doing this work, and then what does this look like? Where do we go from here in terms of our clinical response to adverse childhood experiences and toxic stress? So just as a quick show of hands, what's really helpful, how many people feel pretty comfortable or well-versed in the ACEs research? Okay, and in the biology of toxic stress. So this is great. I love to have to chat to a really mixed crowd because it's an opportunity for we have some expertise, and there's also a lot of learning that we can do. This work really started for me back in, oh my gosh, I would say 2007. So I finished my residency, my pediatrics training at Stanford in 2005, and I, together with the local hospital, California Pacific Medical Center, opened a clinic in one of San Francisco's poorest and most underserved neighborhoods. And this is a place where the if you look at what we call ambulatory care sensitive hospitalizations, right? Those hospitalizations where if you have a clinic in the community that gives good access to high quality care, those hospitalizations tend to go down. Bayview Hunters Point had the highest rate of ambulatory care sensitive hospitalizations for just about every condition. Asthma, diabetes, pneumonia, kidney disease, heart disease, etc. So this is, my goal in opening this clinic was to reduce health disparities. And in doing so, that required, when we look at public health, part of Public Health 101 is when you're working in vulnerable communities, you really have to get out there and put in some face time. And so I did a lot of outreach to communities, going to schools, going to churches, going to after-school programs, and really saying, send us your kids. And crazy thing happens when you do that, is that people send you their kids, right? It was really amazing. And but what I was noticing was one of the number one reasons for referral, so many, particularly teachers and principals and counselors and even school nurses were sending us kids and saying, can you please see Bobby, right? Bobby is hitting the kid next to him. He can't pay attention. He's acting out in class, right? I don't think he's learning. Please, I think he's got ADHD. Can you put him on some Ritalin? But when I did a thorough history and physical exam, what I found was that for most of our patients, I couldn't make a diagnosis of straightforward ADHD. Because for most of my patients, when I was doing the history, what I found was that most of them had such severe histories of adversity that when you look at the DSM criteria, at the time it was a DSM-4, right? That last line tells us, it lists all the symptoms. There were all the symptoms my patients had, but the last line says, and these symptoms are not caused by any other mental health disorder, right? I'm not a mental health professional, but we do know that if it's caused by another health problem, right? And I'm looking in the back, and I gotta call out my sister girl and my dear friend, Dr. Sarah Hemmer, who worked with me at the Bayview Child Health Center since the earliest days. And I'm trying to remember. Sarah, do you remember when we had that patient with neurohemosiderosis? Do you remember that the girl who was lighting bathrooms on fire? And then she had terrible behavior. She was fighting in school. She was, had all these problems. But we also noticed some really subtle findings on her neurologic exam, and her head CT, I think it was a CT, lit up, and her whole brain was filled with iron deposits. Right? We sent her off to California Children's Services because the only symptoms were behavior. She was lighting bathrooms on fire, right? But in that case, it was due to the fact that she was having iron deposits in her brain, right? So you may see a very similar set of symptoms, but the point there is that if there is another underlying cause, then we need to look at that and we need to treat that rather than just treating the symptoms, right? And so that hearing how many of my patients, and really it was to the point where when you see that many patients with significant histories of adversity and also with such poor outcomes, and we're not just talking about behavioral outcomes, right? We're also talking about patients who are having some really significant health problems. The patients that we had with the highest rates of asthma, the most difficult to manage asthma, the most difficult to manage diabetes, autoimmune disease. We got some crazy eczema. I'm looking at there, right? They tended to correspond with some of the worst histories of adversity. And as I was speaking last night, I was talking about a patient that I saw, a 10-year-old girl with asthma, and I was going through with her mom trying to figure out what her asthma triggers were. And her mom said to me, we had done the mattress covers and the pillow covers, and they looked pet dander and all of these things. And when I was asking mom about asthma triggers, she said, doctora, I noticed that my daughter's asthma tends to act up every time her dad punches a hole in the wall, right? And so for me, the public health person in me started to see this in terms of a disease trend, right? That the highest doses, the worst health outcomes co-varied with the highest doses of adversity. And so it was really important for me to understand how is it that adversity in childhood affects children's developing brains and bodies. And that is when how I came across the Adverse Childhood Experiences study. So this was a study that was done by the CDC and Kaiser Permanente, Dr. Vince Felitti at Kaiser and Dr. Robert Onda at the CDC. And Dr. Felitti was an adult medicine doctor, and he was running an obesity treatment clinic. And as he was reviewing a history with one of his patients, he just made a mistake. He normally asked, how old were you when you first became sexually active? But in the course of doing his history, he, instead of saying, how old were you? He just said, how much did you weigh when you first became sexually active? And I don't know if it's because his patient thought the way that he framed it was more medically relevant, or, it was something that doctors need to know, and so gave this information. But her answer was 40 pounds. And what she said was that she was 4 years old, and it was with her father. And that got Dr. Felitti asking, first of all, he was shocked. But second of all, after having a similar experience with another patient, he began to routinely ask of histories of child sexual abuse. And in looking at his next 180 patients, he told me that it was just about every other patient was acknowledging a history of child sexual abuse in his obesity treatment program. And then he enlisted 5 of his colleagues to also screen their next 100 patients, and they had the same findings. And he presented this information at a conference, and people laughed him out of the room. People thought that his patients were just making up stories to cover for their failed lives, right? But one person at that conference was Dr. David Williamson at the CDC, and he said, if what you're talking about if that association is true, it's really important, and we really need to know it. But no one's going to believe you based on 280 patients. So you have to do a large-scale epidemiologic study. And he connected him to Dr. Bob Onda, and together they conducted the Adverse Childhood Experiences study. And they asked it was 17,000, I think 328 patients, something like that, right? Almost 17,500 patients at Kaiser Permanente about their histories of 10 categories of adverse childhood experiences. And these include physical, emotional, and sexual abuse, physical and emotional neglect, or growing up in a household where a parent was mentally ill, substance dependent, incarcerated, where there was parental separation or divorce, or domestic violence. And what they found were 2 things. Their findings were incredibly striking. And what they found were 2 things. One was that adverse childhood experiences are incredibly common. So 2/3 of their population had at least one adverse childhood experience, and 1 in 8 individuals, 12.6%, had 4 or more adverse childhood experiences. Since that original study was done in Kaiser, San Diego, it was published in 1998, so now 2 decades ago. The study has now been repeated. This data has been collected by the CDC as part of the Behavioral Risk Factor Surveillance System, the BRFSS, and in 32 states and the District of Columbia was the last that they reported, but it might be up to 40 states now, I think. All of them report a similar prevalence. Between 55 and 64% of the population with at least one ACE, and between 13 and 17% with 4 or more adverse childhood experiences. So here we can see the state ranking map of the United States of the proportion of children with 2 or more ACEs, and what we see is that this occurs in every geography, right? In every neighborhood, every latitude, every longitude, every racial and ethnic group, and every income level. What we also know is that the prevalence of ACEs is, and the prevalence of high ACEs is higher in low-income communities. So in low-income communities and individuals who are below the poverty line, instead of seeing 12.6% of folks with 4 or more ACEs, it's closer to 27% of folks with 4 or more ACEs. So there's greater acuity in low-income communities, but there is no population where individuals are not experiencing ACEs. So the second finding that Felitti and Onda had was that there was a dose-response relationship between adverse childhood experiences, and not just the stuff that you'd expect, right? Mental health problems, behavioral problems, risk of substance dependence. Yes, there was a dose-response relationship between ACEs and all these health problems. But there was also a direct and dose-response correlation between ACEs and chronic disease outcomes, right? So here we have the 10 leading causes of death in the United States of America. And for an individual with 4 or more adverse childhood experiences, their relative risk of 7 out of 10 of the leading causes of death in the United States of America is dramatically increased. We're talking about for heart disease, double the risk. For cancer, again, double the risk. For chronic lower respiratory disease, triple the risk. For stroke, 2.4 times. For Alzheimer's, 11 times. For diabetes, 1.5 times. For suicide, 30 times. And for those of you in the audience who are deeply steeped in the ACEs data and ACEs research, you may notice that some of these numbers look a little different than the numbers that you're accustomed to from the ACE study. And the reason for that is because these numbers are updated by the global ACE data published by Hughes et al. In a large meta-analysis looking at over 20 countries. So this is the most up-to-date large-scale data on the ACEs, the association between ACEs and morbidity. But what we can see, right, is there is a profound connection between adverse childhood experiences and adverse health outcomes. And for individuals with very high ACEs, the difference in life expectancy is 20 years. Right? Without intervention, we see a 20-year difference in life expectancy. Right? So as a pediatrician, as a clinician, the first thing that came to my mind is how does this happen? Right? Because when we understand how this happens, then we have the opportunity to intervene. That's what we do as pediatricians, right? We do early detection, we do early intervention so that we can improve outcomes. Now, when the initial researchers looked at this data, right, what they thought was, okay, this makes sense. If you have a rough childhood, you're more likely to drink and smoke and do all the things that are going to ruin your health, right? So this really, I mean, okay, we're talking about health outcomes, but really this is about behavior. And they were only partially right, but I'm going to put an asterisk there because if you look at the association between ACEs and health-damaging behavior, there again is a dose-response relationship. The higher your ACE score, the more likely you are to be a smoker. The more likely you are to be an alcoholic. You're 7 times as likely to be an alcoholic if you have an ACE score of 4 or more versus if you have an ACE score of 0. And when we look at teen sexual behaviors, right, we look at early intercourse, teen pregnancy, and teen paternity. Again, we see a dose-response relationship between ACEs and adverse health outcomes. But a funny thing happens is that even when you go in and do the logistic regression analysis and you remove the impact of health-damaging behavior, it only attenuates your risk by about 50%. What? Right? So you're telling me that if someone has 7 ACEs, their risk of ischemic heart disease is 360%, 3.5 times that of someone who has 0 ACEs. And if they don't smoke, they aren't inactive, they don't have a terrible diet, they're still almost twice as likely to have heart disease as a person with 0 ACEs? That hardly seems fair. Right? But what's important about that, and the reason why it's important that some really smart researchers looked into this effect, is because a lot of the way that our society responds to these issues, or a lot of the some of the issues that color the lens with which our society responds to these issues, is, okay, well, I feel awful for this person that they had these experiences, but if they only straightened up and flew right, they wouldn't have these problems, so they're kind of bringing it on themselves. And what we're understanding now is that you can be a saint, but if you had high doses of adversity in your childhood, you're still at dramatically increased risk for many of the leading causes of death. And so my question was why, right? Why does this happen? And ultimately, when we look at this, in order to unpack that, in order to understand that much more deeply so that we can be more effective in our intervention, we have to understand the biology of adversity. And so I've spent the last decade of my life neck deep in research papers on the biology of adversity and understanding how adverse childhood experiences affect the developing brains and bodies of kids. And what we know is that it all boils down to our body's fight or flight response, right? And as a little medical school refresher for those who haven't, experienced it in a while, right? Remember, it goes a little something like this. So you're walking in a forest and you see my friend here, right? This is the scariest picture of a bear that I could find on the internet. But it's pretty scary, I think, right? So what happens, right? Our amygdala sounds the alarm, right? Activates the fear response. And this activates our fight or flight response. Our hypothalamic pituitary adrenal axis leads to the release of high levels of cortisol. Our sympathoadrenomedullary axis leads to the release of high levels of adrenaline, right, from the adrenal medulla. And so, right, our heart starts to pound, right? Our pupils dilate. Our airways open up so that we can take in more oxygen. Our blood pressure and our blood sugar increases, right? So that we can have high flow of oxygen and nutrients and we dilate our blood vessels to our large skeletal muscles, right? Away from that itty bitty muscle that holds our bladder closed, right? So we might pee our pants. And all of this is designed so that we can fight that bear or run from the bear. But if we were to think about it, fighting a bear wouldn't seem like a good idea, right? Because he's big and he's got teeth and he's got claws. And that's why the amygdala sends projections to the prefrontal cortex, right? Our seat of executive functioning and judgment and impulse control, and turns it way, way down, right? It downregulates the prefrontal cortical activity. And instead, it upregulates or activates the noradrenergic nucleus of the locus ceruleus, or as I like to call it, the part of the brain responsible for I don't know karate, but I do know crazy, right? This is the within the brain stress response center, and it's responsible for getting us amped up. And then the other thing that's a little bit less obvious is that when we activate our stress response, we also activate our immune response. Because if that bear gets his claws into you, you want your immune system to be primed to bring inflammation to stabilize that wound so that you can live long enough to beat that bear or get away. It's brilliant. It was evolved over millennia so that we could reproduce. But the problem is what happens when that bear comes home every night. And this biological mechanism is activated over and over and over and over and over again. And it goes from being adaptive or life-saving to maladaptive or health-damaging. So, and children are especially sensitive to this repeated activation of the stress response, right? Because their brains and bodies are just developing. So high doses of adversity in children affects the developmental trajectory, not only of their brain and nervous system, but of their developing immune system, hormonal systems, and even ultimately the way their DNA is read and transcribed. So in the neurologic system, what we see is dysregulation of that sympathoadrenomedullary axis and the hypothalamic pituitary adrenal axis. They become overactive and they lose their feedback inhibition, the ability to shut itself off. So normally, you pump out a bunch of cortisol, right? You get to a certain amount, and then cortisol feeds back on the hypothalamus and shuts off the HPA axis, right? We lose that feedback inhibition when kids are exposed to very high repeated adversity. We see overactivation of the amygdala, leading to an increased fear response. And in studies of kids in severe institutionalized situations like Romanian orphanages, you can actually see a measurably enlarged amygdala on MRI. We see inhibition, long-term inhibition of the prefrontal cortex, leading to impaired impulse control, executive functioning, difficulty with judgment, right? All those symptoms that my patients were being referred to me for by folks who were concerned that they might have ADHD. We see toxicity of the hippocampus, leading to difficulty with memory and learning. And here's when, remember when I was talking about that dose-response effect between adverse childhood experiences and high-risk behaviors? And I put a little asterisk there. Now I'm coming back to that asterisk. Because what we also see are changes to the ventral tegmental area, the reward center of the brain. And the VTA works together with the nucleus accumbens, right? There are brain's pleasure center, and it's activated by cocaine, heroin, methamphetamine, just about every drug of abuse, right? Weed. It's also activated by sex. It's also activated by high sugar, high fat foods, gambling, etc. So when we're talking about the fact that a person with 4 or more ACEs is 10 times as likely to be an IV drug user, it's not just because they had bad parents, right? Or they didn't learn the right ways to walk through life. It's also because the dopamine receptors and the structure and function of the ventral tegmental area, the reward system of the brain, is altered when children experience high doses of adversity. And so that's really important for us to understand. But one of the reasons that I'm really excited to talk to you all today is because I think now in our society and our culture, we're beginning to kind of get that early adversity can lead to problems with brain development and behavior. And when we hear folks talking about ACEs and toxic stress, most of what we hear is about the impact on brain development and behavior, right? And that's really important, and that's built off of the last several decades of neuroscience work, which has been the scientific foundation for this work. But what I want to tell you all is don't forget about the rest of the body. High doses of adversity are associated with increased inflammatory mediators and markers of inflammation, inhibition of anti-inflammatory pathways, and that leads to increased risk of viral infection, certain bacterial infections, and long-term chronic inflammation. When they measure inflammatory markers of adults who have experienced adversity from childhood, what they see is higher rates of inflammation among these adults. We also see that for an individual with 2 or more ACEs, in the original ACE study, for individuals with 2 or more ACEs, they had double the risk of autoimmune disease as compared to an individual with 0 ACEs. Our patients who come in with behavioral problems, who come in who are referred by their teacher because they can't behave, they are the lucky ones. They are the ones who get identified. The kids who are dealing with severe asthma or autoimmune disease or frequent infection that may be a result of the dysregulation to their system because of the high doses of adversity that they've experienced, we don't recognize them. I guarantee that every single clinician in this room sees, I'm going to say, what do we know? At least, let's take the lowest national estimate out there. At least 50% of the kids that are walking through into your clinic every day are experiencing at least 1 ACE, right? And probably, let's go with a low estimate, probably 10% experience 4 or more. And it affects their immune system, right? And for a lot of us, we aren't detecting it. We also see long-term changes to our hormonal systems, long-term changes to adrenal corticotropic hormone, cortisol, adrenaline, and other hormones that lead to increased stress activation in the body, right? Increase in this biological stress activation. Changes in growth hormone, thyroid hormone, pubertal hormones that lead to changes in growth, development, metabolism, and puberty. Changes in leptin and ghrelin, which lead to increased risk of overweight or obesity. And then ultimately, right, when we look at how early adversity leads to these long-term health problems, right, increased risk of heart disease and stroke, that's stuff that happens long after folks have left their parents' house. What we see is that high doses of adversity are associated with changes to our epigenetic regulation. So not your genetic code, but the genetic markers that regulate how our DNA is read and transcribed. Epigenetic means above the genome. And these are markers, the DNA methylation and histone modification, things that change the way that the DNA unfolds, and they're markers that tell us which parts of the DNA should be read so that the cell understands which receptors they should upregulate or downregulate, how much of a certain protein product they're going to create, right? That epigenetic regulation is significantly affected by early adversity. And so these changes to the way that DNA is read and expressed leads to changes in the way the brain and organ systems respond to stress. And we also see premature telomere erosion, right? So telomeres are these bumpers on the ends of our DNA. They protect our DNA from wear and tear. The faster they wear out, the faster that cell becomes senescent, right? It has premature cellular aging. And we know that telomere erosion is accelerated by certain things. It's accelerated by toxins. It's accelerated by byproducts of combustion from tobacco. And it's also accelerated by early adversity. And when those telomeres get too short, too fast, the cell no longer does it. One of two things happens. Either the cell no longer does its job well. So if you're an islet cell in the pancreas, that means you're not making insulin anymore, right? And then that leads to diabetes. Or the other thing is that the cell, when it goes to replicate, it replicates incorrectly, right? And then we see increased risk of cancer. So what we now understand is that when we have early life adversity, right, that is moderated by the effect of protective factors, right? I'm going to talk a little bit more about that in a second, as well as predisposed vulnerability. So there's some genetic vulnerability that factors in as well. And that leads to neuroendocrine immune. And I'm going to beg y'all, don't forget the endocrine and immune. Neuroendocrine immune disruption, right? But the root of all of this disruption is fundamentally an overactive stress response, overactivity of the HPA and SAM axes. And that leads to all of these long-term health problems. Now, one of the big challenges with the ACE study was it was done in adults, and we said, which of these did you experience as a child, right? So when the ACE data came out, it was important, it was groundbreaking, but for a lot of folks, adult medicine folks say, hey, what do you want me to do? This is stuff that happened when they were kids, right? And pediatricians said, well, what do you want me to do? I have no idea whether this child is going to develop these health outcomes later on down the line. How am I supposed to track if the intervention that I'm doing is preventing heart disease? My team and I at the Center for Youth Wellness felt like it was really important for us to understand, well, are there signs and symptoms of toxic stress that we can identify in kids? Because if there is, then that will help us be able to understand whether our interventions are being effective in mitigating these effects. And it turns out that the signs of toxic stress are identifiable as early as infancy. So high doses of adversity are associated in infancy with developmental delay, growth delay, failure to thrive, and sleep disruption. So when you see a mom coming in and she said, God, my kid won't sleep for the life of me. Oh, I got a newborn, it's driving me nuts, right? In that long list of anticipatory guidance that you're doing with that parent, do not forget about childhood adversity and adverse childhood experiences. In school-age kids, we start to see increased risk of asthma, pneumonia, viral infection, atopic disease, learning difficulties, and behavior problems. And as kids get older, we're more likely to see obesity, diabetes, headache, abdominal pain, teen pregnancy. We have hyperthyroidism, but it's really autoimmune disease. As well as pubertal changes. So when we first learned about this information, one of the first things that we did at our center was we did a chart review. We went back and did a retrospective chart review. We looked at 702 charts of our patients to see, hey, is this even happening with our kids? All right, it might have happened to those adults in Kaiser, but I'm not gonna, I'm a scientist, so I need to get my own empiric data, right? Maybe it's not happening in Bayview Hunters Point. I know Sarah's laughing at that. And what we found was that very similar to the original ACE data, 2/3 of our kids had at least one ACE, and 12% of our kids had 4 or more ACEs. But the big difference was that the mean age for the ACE study was 55 years old, and the mean age for our population was 8 years old. So for our patients, many of them had not finished accumulating ACEs over their childhoods. But what we found was for our kids who had 4 or more ACEs, they were twice as likely to be overweight or obese, and they were 32.6 times as likely to have learning and behavior problems in school, right? And this was really powerful. So our kids who had 4 or more ACEs, more than half of them had learning and behavior problems. I just want to take a second, right? Because we see this same dose-response relationship. But I just want to take a second to just think about that effect size, right? If there was some, food additive or packaging material or some other thing that had this type of effect size, right? That when you get to 4 or more, you're seeing 32 times the risk for learning and behavior problems, right? We would be marching in the streets. Every mom in America would be like, get this out of my community, right? And yet, most folks don't even know, most parents don't even know that adverse childhood experiences put their child at that great of a risk for having these problems. And the other challenge is, what were these kids being referred to me for? ADHD. What's the #1 treatment for ADHD in the United States of America? Stimulants, right? Ritalin, Adderall, Strattera. But it turns out when we look at the biology, and this is why understanding the biology is so important, when you look at the function of the prefrontal cortex relative to catecholamine, right? If you have not enough, you have underfunctioning of the prefrontal cortex. And that is why Ritalin is the #1, or stimulants are the #1 intervention for ADHD. Because if you have there's a fair amount of ADHD out there, or if it's, in my opinion, true ADHD, you have the underfunctioning of the prefrontal cortex. You add some stimulants, and you improve functioning. You come up on that U-shaped curve. But the problem is that if that child is experiencing a toxic stress physiology, they're much more likely, right, to be over here. Same level of functioning, but instead of it being caused because of low amounts of catecholamine, it's being caused by excessive amounts of catecholamine. And in that situation, right, adding a stimulant may not be the right intervention. In that situation, the intervention has to be reducing the dose of adversity and enhancing the ability of the caregiver to be a buffer to that child's stress, which in effect reduces the dose of catecholamine, right? That's how we reduce the dose of catecholamine. At this point, Merck hasn't yet come up with a drug that's going to, chelate those high levels of stress hormones out of a kid's blood. But the good news is we do have a lot of interventions that can reduce this overactivity of stress hormones. And what we know and what the science shows us is early identification and intervention are absolutely critical. And I want to share with you a little bit of what that looks like, right? So now that we know all this science, what do we do? Well, in our center, what we did was we started with routine screening of every single one of our patients for adverse childhood experiences. Because if a patient comes to me, is brought in by their teacher, by their parent, or is referred by their teacher for ADHD or asthma or some other health condition, I want to know their ACE score. But their ACE score tells me whether or not I'm likely to be dealing with a toxic stress physiology, and that informs my clinical approach. And I'll show you a little bit about what that looks like. So, 2-year, 9-month female presented to me for a well child exam, and her presenting concern was that the patient was small, but otherwise no concerns. She had a little bit of diarrhea when she started on cow's milk, but those symptoms went away. Mom changed to almond milk. Otherwise, well, no complaints. She was born full-term, vaginal delivery, 6 pounds, 8 ounces, 25th percentile for weight, 50th percentile for length. And she had normal developmental history. Normal gross motor, fine motor, social, emotional development. She walked at 14 months. She had precocious language development, and she had no behavior concerns. But when I looked at her growth, her weight went from the 25th percentile for weight and 50th percentile for height to progressively decreasing until she was consistently below the 3rd percentile for height, weight, ultimately head circumference, and then ultimately BMI. And her previous pediatrician had been prescribing Pediasure, right, and recommending that they offer more foods, but it didn't seem to help. And both mom and dad, they're not giants, but they're within normal limits. So this is her actual growth curve, and what you'll see is that her growth starts here and then tapers off in terms of her height and then her weight. And if I showed you the growth chart for her head circumference, you would see the same pattern. So when I did her evaluation, she had a normal physical exam. I did, CBC, CMP, normal initial labs, and we didn't end up getting a bone age till a little later. But the one thing that we did find was that she had a delayed bone age, which is actually something that's common. So her bone age was at a 2 years, 6 months old when she was 3 years, 7 months old. But her ages and stages questionnaire was normal. Her MCHAT was normal, so no developmental concerns. Her ACE score, which we do part of routine screening, was a 7 plus 0. 7 with the traditional Validi and Onda questions, and then we also ask about other things that we believe can be risk factors for toxic stress. Things like discrimination and community violence and bullying, etc. So seeing that ACE score, for me, now gave me a really important piece of clinical information, which was that the most likely reason that this child was failing to thrive was likely because she had been exposed to 7 out of 10 of the adverse childhood experiences that we had listed up before, and that her body was likely making stress hormones. And that was what was most likely to be interfering with her growth. And so when we look at the interventions that are most effective in reducing stress hormones, reducing inflammation, and enhancing neuroplasticity, right? So directly countering a toxic stress physiology. Those include sleep, exercise, nutrition, mindfulness, mental health, and healthy relationships. And for this almost 3-year-old, what we prescribed was child-parent psychotherapy. right? This is a dyadic intervention that works with both mom and child to be able to address not only what's going on in the child's home, but what's also going on for mom that makes it so difficult for mom to create a safe environment for her child. Right? And in this particular situation, one of the pieces that was really important was also framing and sharing with mom what was going on in the first place. So in addition to continuing the Pediatric, right, making sure she has WIC so that she can get that, when we did this child-parent psychotherapy, one of the things that I explained to mom, I said, I think because of what your daughter has experienced, her body's making more stress hormones than it should. And this may be affecting her growth, right? So we have a kid with no behavior problems whatsoever. And I said, I want to refer you to a specialist to help you learn how to support her and reduce the amount of stress hormones her body is making. We also know that a healthy caregiver is one of the most important ingredients for healthy children. So an important part of helping your daughter heal will involve managing your own stress level and practicing taking care of yourself. This was my treatment. So we did this multidisciplinary care. We did a warm handoff in this situation. And the other piece that was really important was also making sure that the child-parent psychotherapy practitioner also knew what the intervention was, knew the diagnosis and our treatment approach. And so once we had buy-in for the entire team, what we saw was a significant improvement in this case, her BMI, right? She started gaining weight again, and she got back on the growth curve. So the thing that I think is really important to keep in mind here is that when we're talking about this toxic stress response, don't forget, we know that we're familiar with the neuro, but keep in mind that it's a neuroendocrine, immune, and genetic regulatory disruption. Now, one of the big challenges that we have is that there's currently no established clinical diagnostic criteria for toxic stress. Right? And that's why we use the ACE score, because the ACE score tells us which patients are at high risk for toxic stress, which patients are at moderate risk, and which patients are at low risk. And right now, that's the best of the information that we have to go on. But this can help us understand how to deliver more effective and more efficient care. And the treatment strategy is to reduce the dose of adversity so that we can decrease activation of the fight or flight response and decrease the effective dose of adrenaline and cortisol. Enhance the ability of the caregiver to provide that safe, stable, nurturing environment. And we know that for little kids in particular, a 2-gen approach is really important. And as kids get older, you can do more individual work with the child. One of the things that I think is a fascinating corollary to this case is that this patient's 9-month-old brother, who was not the index patient, right? So when I say that when the issue is not behavior, in this case it was growth, so we could, we identified it. But the patient's 9-month-old brother, who is not the index patient, had 4 ear infections and 2 pneumonias in his first year of life. And his mom said it seemed like he was always sick. And I even, 4 ear infections, referred to ENT, right? Who, didn't see anything terribly wrong, said we'd follow it. But after we started this child-parent psychotherapy intervention, and we helped mom understand how to reduce the level of stress hormones her kids were producing, this patient had many fewer URIs and did not have a single other ear infection or pneumonia after he began treatment, and we've been following them for over a year. So at the Center for Youth Wellness, what we're recognizing is that screening for ACEs is an important tool to help us understand how to give our patients more effective and more efficient care. But we don't expect every pediatrician to invent their own protocol on how to screen for ACEs. We don't want anyone to reinvent the wheel. And that is the reason why we created the National Pediatric Practice Community for ACE screening. Because what I hear from my colleagues all around the country is, you know what, we believe you. We are on the bandwagon. We think this is important. but we don't know how, and it feels like there are obstacles, right? And what do we do when you get a positive ACE screen? And so the National Pediatric Practice Community is an opportunity and a venue, a digital platform to allow pediatricians and child-serving primary care clinicians, you don't have to be a pediatrician, you can be a nurse practitioner, you can be a family practice doc, to be able to learn together about how we screen for adverse childhood experience. And share your obstacles, surface the problems that you have, surface the questions that you have, and that we will work together as a community to be able to solve them. So when you go on the website, you'll see the research, you'll see screening tools, you'll see even some ICD-10 and CPT codes, right? Which are and this is a co-created community where we advance the practice of the detection and treatment of toxic stress together. And here, Dr. Ruth is one of our pilot sites for the National Pediatric Practice Community. You all are doing this incredible work right here in Santa Barbara, and there's an opportunity if you want to learn more to, I think, sign up, right? But toxic stress is one of the greatest public health crises that is currently under-recognized and dramatically under-treated that is facing our children today. And we are on the front lines. We have the ability, right? And hopefully, more and more we have the tools, we have the leadership, we have the community, right? We're developing these practice tools to be able to identify and address toxic stress in the primary care setting. We can change the narrative for the next generation of children, and it begins with each one of us today. So I want to stop there. And it's right before 9. I'm going to take a moment if there are maybe 1 or 2 questions, and then I know you guys are all incredibly busy. So that is a great question. So we actually use something called a de-identified screening tool. And let me see if I can pull it up real quick. But we use a de-identified screening tool. And it looks like this. So we have the original ACEs right here. And we don't ask patients to tell us which ones of the ACEs they've experienced, only how many. So we list the 10 traditional ACE criteria, and when I say that the score was a 7 plus 0, literally what I get in that box is a 7 right there, and then we added some supplemental criteria, including foster care, harassment or bullying, parent or guardian who died, separation from your caregiver through deportation or migration, medical trauma, serious medical procedure or life-threatening illness, community violence, or discrimination. And so we get a separate number there. The reason that we separate those numbers, and I think it's really important, is because when you get a number in the top box, we have large data sets, right, from epidemiologically robust studies that tell us, so I already know, we know from the National Child Health Survey, 90,000 kids, that if that number on the top box is a 4, that child has double the risk for asthma, right? I know that. But if that bottom box is, if the top and the bottom together are a 4, I'm not sure what that means in terms of relative risk of these common disease conditions. So we have more work to do on some of the other risk factors for toxic stress. But one of the questions that people also ask is, how do you, these are the 10 traditional ACEs, why do you ask these about and not the others? And I think it's really important for us to be able to demonstrate the ROI, right? So when we say, oh, that number is a 4, I know that that patient has a relative risk of developing lots of different health conditions, and I can quantify that risk. So I know that if I do really good population disease management, right? If we do really good prevention, and we cut that ACE score from the mean population prevalence, right? let's say we cut it in half, right? Or let's say we cut in half the number of individuals who have 4 or more ACEs. I can now quantify how much money we're saving the various payers, including the federal government and others, and I want that money. Because in order to do this, you guys, we're going to need a lot of money. And we need to be making that case, and that is what these methodologies in terms of collecting data allows us to do. There are a number of interventions. So there are a number of best practices, and I kind of touched on them, but I didn't dive as deep into them as I would have liked to. Integrated primary care and behavioral health is, I think, part of the gold standard, right? Being able to, when I talked about sleep, exercise, nutrition, mindfulness, mental health, and healthy relationships, one of the things that's really important about that is that I'll tell you something totally nutty that we learned when we're looking at our data from the first 5 years of running the Center for Youth Wellness, is that when we identified ACE scores in our patient, we have integrated primary care and behavioral health, we have team-based care, those are 2 of the gold standards. Still only about 50% of the patients that we refer for integrated care actually get integrated care. Right? And we have like the gold standard team. And part of the reason is because a lot of the stressors and drama that make it difficult for families to get that, just to follow up on that mental health care. By the way, a lot of the same families are, we refer them to the cardiologist and they didn't make it to that appointment either. We refer them to the endocrinologist and they didn't make it to that appointment either. And so what we're understanding more and more, which is, why I'm here talking to y'all, is because increasingly we need to understand how to manage this in primary care. We need to have integrated care. We need to have team-based care. Those things really, when kids get that care, their outcomes are really much better. But understanding, for example, culturally, there are many communities that are very shy in getting mental health care and engaging mental health care, and there's a great deal of stigma. So understanding how we as clinicians can, for example, do anticipatory guidance with families in terms of other modalities that include things like getting regular exercise, right? Working with families on sleep hygiene, working with families on understanding, okay, I think it makes a real difference when a pediatrician says to a parent, right, what's going on in your household is affecting your child's health, so you need to work on your self-care, right? Because that is what is going to help to heal your child. And it may be that you have the opportunity to make that connection, or it may be that you're counseling and advising, right? Doing anticipatory guidance with that family to say, you know what, Mom, I'm going to really, really highly recommend that you seek a domestic violence shelter, because this is harming your child's health. And even if you don't have the capacity to make that individual connection and walk them down to the domestic violence shelter, right? Arming them with that knowledge is so important, because what I find is that these issues happen most often chronically in families, and they're families that I will see sometimes for years, telling them the same stuff over and over again. They're not getting mental health, and they don't engage with the services. And then one day something will happen, and the stuff that we've been talking about for so long clicks with that caregiver, most often with the mom, and in that moment they will seek that help, whether it's internally from the sources that you have within your practice, or in the community at a domestic violence shelter, at La Casa de las Madres, at a church organization. But they have to know what the problem is first. And one of the big issues that we're seeing is that most families don't know what the problem is. And what I see in my practice, and I'm sure you'll see this in your practice as well, many parents are willing to do for their child what they have not been able to do for themselves. And understanding, helping them, at least arming them with the information, right? Like when we see a family come in and they've got a cold, there's no cure for the common cold. We're not writing prescriptions to treat rhinovirus. But what we are saying is, this is what it is. It's a cold, right? So this is what you do. You got to rest, and this is what to look out for. And here's when to come back. And here's the etiology. And here's how we recognize the difference between this condition and another condition. And what I've seen, not just in talking with doctors, but also talking with folks who are doing community-based organizations around the country, is that there's a center called the National Crittenden Foundation where they do ACEs education and intervention with pregnant and parenting teens. They're not a healthcare facility. They're not even a mental health facility, right? They do women's empowerment. And what they find is that the young women that they work with, they say, oh my God, now I finally know what's been going on with me. And in fact, the women in their program, the older women who are like 20, started telling the younger women, hey guys, this is what's been going on. They talk to their siblings, they talk to their cousins and their girlfriends, and they say, this is it, this is what's been going on with us. And when I went and spoke at their national conference, what was so moving to me was that all these young women were coming up to me saying, my ACE score is a 10, but my kid's ACE score is a 3, right? My ACE score is a 9, but my kid's score is a 2, and I'm committed to keeping it that way. And I believe that knowledge is power, and arming families with this information is healing. This is a public health problem, and that's the good news, right? Because if we're trying to treat each individual case one by one, it's going to feel like we are trying to boil the ocean. But public health affords us tools, and that we are actually really good at doing in the U.S. So the first thing that we need is routine screening, right? Public Health 101, when we look at the Wilson and Youngner criteria for screening, toxic stress meets all of these criteria. It's something that is prevalent. It has a latency phase. It's something that you can intervene, and all the data shows that when we do early detection and early intervention, we improve health outcomes for kids, right? And so what that means that we now need policy action, which means we need advocacy. And that is the other thing I love about being a pediatrician, is because when you look at all the physicians that are out there, pediatricians are the most active in terms of advocacy. We have a very important role, not only in treating our individual patients, but also being part of the voice of advocating for patients, for screening, for resources, and also a really critical piece is raising awareness. The practice of routine screening in our practices raises awareness for every family that we experience, regardless of whether they have ACEs or not, right? Every family we encounter. Our center is also launching an initiative called a Stress Health Public Education Initiative. And we're getting ready to put out tons of Facebook ads. Facebook is coming under some heat lately, so that was a much more exciting strategy a little while ago. But putting out Facebook ads, and these spots are 15-second spots. And they say, toxic stress increases your kid's risk for heart disease as much as feeding them 33 strips of bacon a day, right? Which is, we did all the calculations, the relative risk when you take high doses of adversity, and then you look at the impact. And most parents, and the impetus there is just to help parents understand, well, I definitely wouldn't want to feed my kid 33 strips of bacon a day because I know that's damaging to them. And the point of that campaign is also to help families understand that it's not just behavior. It's not just something that if they remember, because there's a myth out there that if kids are little, even if they're exposed to some pretty awful stuff in the household, if they don't remember it, it doesn't bother them, right? And it doesn't harm them. And that's false, and that's a myth that we need to be out there identifying and correcting in our society.
Any damage is done in utero that you can speak to?
So this is a fascinating bit of research and data, and it turns out that it's not just the in utero health, which we know that exposure to high dose of adversity during pregnancy, number one, is associated with negative perinatal outcomes, right? So increased risk of miscarriage, preterm birth. In the original ACE study, if there was a teen pregnancy, for the women in the study who got pregnant as teenagers, if they had 4 or more ACEs, their relative risk of having fetal demise was 1.8, right? So 180% as likely to have fetal demise as the women who had 0 ACEs, right, in this large population. So we see negative perinatal outcomes. We also see some, and it's not as clear exactly what the relative risk is, but increased risk of developmental and behavioral problems, including autism, frankly, including other developmental and behavioral conditions when there's high doses of adversity during pregnancy. But here's what's nutty. It's not just prenatal health, it's also preconception health. So it's this chicken-egg issue that when mom has high doses of ACEs in her own history, when moms have high ACEs, because we're talking about long-term changes to the stress response, right? So if a baby's being gestated and that mom has an overactive stress response and has a chronic toxic stress physiology, right, that's gone unmanaged for decades, that also poses increased risk for perinatal outcomes and health and developmental outcomes. And so there is, when we talk about a public health crisis, there is true urgency for us on a public health level, on a national level, to begin to do routine screening, early detection, and early intervention so that we can do for toxic stress what we've done for HIV/AIDS, which is dramatically reduce the morbidity and mortality, and we can do it in 2 decades. We can do it in 1 generation, dramatically reduce the prevalence of ACEs. I'm going to end there. Thank you so much for your time and your attention.